LASIK or the corneal laser refractive surgery, it started with PRK, went on to LASIK, and now it's again shifting back to PRK. So I'll let you know what are the factors why we are shifting back to the surface ablation. So basically, surface ablation covers three things: the PRK, the LASIK, and the transepithelial PRK. I'll be talking about these three things. So it was MacDonald who treated the first sighted human eye in 1988, but later on the LASIK got popularized and the PRK went into hibernation. So surface ablation has returned as an alternative in specific indications such as a very low corrections and in thin corneas, and it's coming back again. So why we are coming back to PRK? So LASIK flaps were thought to be associated with increased post-operative higher order optical aberrations than PRK. The very cut of the flap used to induce higher order aberrations, and post-operative quality of vision was considered better with wavefront guided PRK than with the LASIK. However, recent data have suggested that both techniques are effective with equal vision and equal higher order aberrations at 6 months in post-operatively. So what are my indications of doing PRK? When would I would like to do PRK? So in the deep set eyes and narrow palpebral fissures, where it is very difficult to fit the suction rings, very difficult to insert the microkeratomes. So there I would prefer PRK. Thin corneas, of course, you are saving more tissue, you are saving more stroma. Steep and flat corneas, the microkeratomes won't work on steep corneas or the flat corneas. They would either cause improper cut or they may cause buttonholing. And to correct post-operative refractive corrections, such as refractive surprise after a cataract surgery or a residual refractive error after a laser vision correction, after PKs, after therapeutic keratoplasties. Low to moderate myopia or hypermetropia can be treated with PRK. My limit is up to 6 diopters. I have done up to 7 diopters also, and there are reports of being people going up to -8 diopters. But standing here, I would recommend -6 diopters. Why? Because higher correction, higher ablation, more tissue ablated, there are more chances of haze, post-operative haze. Person who want to go in for contact sports such as football players or the martial arts players, people going in for defense services, I usually prefer doing PRK in them. And patients with epithelial basement membrane dystrophies and diseases, it's better to do a PRK than to make a flap. And of course, the retreatments I have talked about. Preoperative evaluation, I'll just skip this because this has already been covered. I would not like to repeat it. There's nothing which I would like to add on to this. Let's come down to the technique. Technique basically involves removal of the epithelium first, then reshaping of the cornea with the LASIK, with the laser, and then you apply the MMC to decrease the haze, and then you apply a BCL, a bandage contact lens. Now, basically, there are 3 ways, there are many ways, but I will be talking about 3 ways of removal of epithelium. You can do it with the help of an alcohol, you can do it manually, or you can do it with the help of a laser. That is, you can do a PTK and then a PRK. So just a quick animation video of alcohol assisted. You mark the cornea 8 mm with the help of a trephine, centering it onto the cornea. Keep an alcohol well over it. Put 20% of alcohol. Keep it for 20 seconds to 30 seconds, whatever is appropriate for you. Usually 20 to 30 seconds are good enough. And then the epithelium comes out very, very smoothly and gives you a very smooth surface. And then you do your laser ablation. And after that, applying mitomycin C, and then you put bandage contact lens maybe for 4 to 5 days until your epithelium regenerates. Just the same thing, a video. So you put the alcohol well, put in 20% of alcohol. The video says 40 seconds, but for me 20 to 30 seconds are good enough. Before you remove the alcohol, make sure there's no alcohol left onto the cornea. If it spills over, it's going to cause a lot of irritation. If it spills over into the pharynxes, it's going to cause a lot of irritation to the patient. You wash it off very thoroughly, and then if you can appreciate that the epithelium comes off very smoothly. So it's basically you need to go from the periphery to towards the center. That's a good way of removing the epithelium. And then the laser is performed. This is not my video. I have taken it from the YouTube. And then you apply mitomycin C. You soak a sponge in mitomycin C and you can leave it there for 30 seconds, whatever is your nomogram. I'll just let you know about that. And then you wash it off with sufficient amount of BSS so that no mitomycin C is left. And then you apply a bandage contact lens. Manually, you can do it manually as well. It looks very untidy, but there's no chemical contact with the cornea. So first we do a SCC, that is a static cyclotorsion, and then we remove the epithelium manually with the help of a hockey stick knife. It would be a good idea to pre-mark about 8 millimeters before you start removing. Wash it off thoroughly, rinse the cornea. Then you need to dry the cornea before you start your laser, because 193 nanometer will not pass through a wet surface. You do your ablation. And then you apply mitomycin C. This is how I apply. I put a drop of mitomycin C and spread it all over the denuded area of the cornea. Leave it for 30 to 30 seconds, depending on the myopia corrected or depending on the ablation performed. And then you wash it off with sufficient amount of BSS, at least 20 to 30 ml, and then you apply your bandage contact lens. And then comes another thing which is known as transepithelial photorefractive keratectomy. So this is basically a surface procedure. PRK profile, you do a PRK profile for the refractive error correction, and then over that you do a PTK profile for epithelial removal. So basically it is a no-touch technique or the non-touch technique. So it is basically PRK plus PTK done in a single sitting without any break. The machine has, I have a Schwinn machine which does it in one go. It first does the PRK profile and then the PTK profile. So what you do is you first take the epithelial map, you do the epithelial mapping, you note down that it is about 55 microns in the center and about 60 to 65 centimeter in the periphery. So you go and feed these values here in the machine. You tell them that, okay, centrally I want 55 microns off, and in the periphery I want about 65 microns off. And then you feed in all the patient values. So this is what the machine is going to do. Machine is going to do a PRK profile followed by the epithelial profile. So it's first going to ablate the number, and then it is going to go 55 microns in the center and 65 microns in the periphery. Just a small animation video. Do I have the time?
To carry out no-touch or laser surface ablations. TransPRK treats refractive errors by superimposing an aspheric ablation profile with a defined epithelial thickness profile based on literature values and mean epithelial profiles of large-based populations. The TransPRK is a transepithelial single-step treatment that avoids the eye coming into contact with any instrument. TransPRK is an advanced surface laser treatment because the epithelium is removed by the excimer laser more precisely and uniformly than with either manual or alcohol-assisted debridement. TransPRK applies an epithelial thickness profile that is thinner in the center than in the periphery. Because TransPRK applies the laser beam directly over the epithelium, it acts as a smoothing agent for the residual stromal bed. TransPRK applied to regular corneas provides efficacious, safe, stable, and reliable results. TransPRK in combination with corneal wavefront is preferable for patients who need retreatment after radial keratotomy or corneal transplantation. Moreover, it can be used to treat haze, scarred corneal tissue, and keratoconus before corneal collagen cross-linking. TransPRK is a versatile approach. It's useful in all cases where a difficult epithelial flap is expected or when the epithelium covers corneal irregularities of the stromal tissue. To carry out,
and this is how it's done. I'll just quickly go through it. Once you do a cyclotorsion test, SCC, you map the iris, so it compensates for any cyclotorsion. You dry the corneal surface. That's all you need to do, and then the rest thing is being done by the laser. You fire the laser right over the epithelium. First it does the PRK profile. Without stopping in between, it goes to the PTK profile for removal of the epithelium. So it's very quick, it's very fast. And then of course you apply the mitomycin C as usual and wash it off and then apply the bandage contact lens. So basically this has the advantage that it's an all laser, no touch technique, and it is a one-step procedure, no cut, no flap procedures, so no chances of any flap complications, and it's a minimally invasive procedure. Further, it allows for true customization, less chances of dry eyes, less chances of ectasia, and it's suitable for sport person, military personnel, etc. Now, PRK has its own disadvantages also. So, pain is one of the most important disadvantage or the drawback of PRK. Second was the haze, and then was the slow recovery and regression. So, all these things were taken care of. Pain was taken care of. Dr. Rohit Shetty and the Narayan Netralaya people, they have taught us by soaking your bandage contact lens for 20 minutes in AccuVeil, or for 20 minutes, if you soak your contact lens in AccuVeil and then you apply, this acts as a depot for on the cornea, and it reduces the pain significantly. We have been using this for quite some time, more than I think 2 years now, almost it's 2 years now. Corneal haze can be taken care with the help of mitomycin C. We usually use 0.02% of mitomycin C. We apply it for 30 seconds. If the ablation is less, if the tissue is being less ablated, we may reduce it to 20 seconds. And if I go beyond 3 diopters, suppose I'm going for up to 4 diopters, then I'll increase the contact time by 10 seconds. 10 seconds for each diopter beyond 3 diopters. So this is what I follow. Then there's a new substance which is known as SAHA, which is, I'll just quickly sum up. This slide has been provided by Dr. Rohit Shetty to me. I would like to acknowledge this slide from me. So this new substance, it causes less of reduction in the myofibroblast, and it's supposed to be better, but it's still in the animal testing phase. And it gives you an optimal outcome comparable to mitomycin C, but more number of myofibroblasts are saved, and it doesn't have any effect on the endothelium as well. Next is the smart pulse therapy. This SPT takes care of the slow recovery. The recovery is fast after this technology. We don't have time. Maybe once we have a time, we'll talk about that. Conclusion, PRK is a reasonably safe procedure, effective and predictable technique. There are no flap-related complications, and it's a preferred technique in thin corneas and dystrophies. Thank you very much for your time.